So good morning to each and everyone, to all our viewers of IT Talks. Myself Shivang Sharma and my co-host Sneha Kamalpuria welcomes you to another exciting episode of IT Talks, episode number 21, with the topic of penetration of IT in healthcare sector. Today with us, to our honors, we have Dr. Vasudha Sharma, ma'am. So first of all, a very good morning, ma'am, from India. According to you, it must be evening, but a very warm good morning to you, ma'am.
Yes, thank you so much for having me.
And also to all our pleasure, according to Indian Standard Time, today is ma'am's birthday, so a very happy birthday to you, ma'am. That
Not today, not today.
okay, so a pretty happy birthday, not an issue for us.
But thank you. Yeah, I am really my apology if I said I am celebrating an event today related to birthday, but yeah. See, in my since my childhood, we never celebrate a day. We celebrate the entire month.
that,
So
that's
it's
that's really good.
reliving the old memories.
That's really good, ma'am. So before starting with the event and before starting with the discussion of what actually IT does in healthcare sector and how actually it helps people around, let's start with the introduction of Dr. Vasudha, ma'am. Dr. Vasudha Sharma is a traveler by chance, writer, photographer by choice, and a health and wellness promoter by profession. Coming from Delhi-based family, she has decided to follow a different path rather than just to be the part of a trending dream of a being doctor and engineer. Being in love with vibrant mustard farms and crisp mountain air, she got selected in one of the best biomedical colleges in Dehradun. During her hostel and college days, she earned a very enriching experience and very impactful insight to friendships, relationships, and cultural diversity. This experience has pivotal role in her life as it assisted in making her in better problem solver and develop an intuitive heart. After getting married, she moved to Los Angeles with her husband, and soon she started working on getting her credentials evaluated to become a licensed physical therapist. To her shock, she found out that it was harder than she thought and had started taking various courses and evaluations. Her first 3 years of coming to US became a back to school from scratch period. Her never giving up attitude and efforts bore fruit, and she passed the national boards in a first attempt with flying colors. This still did not suffice her requirement to practice in California as a physical therapist, as she was supposed to work for 6 months internship under half wages to obtain her license. At the point, she decided to apply to any other state which can honor her credentials and give her back her career. She finally found an answer to her prayers in Idaho. Her first job was in the small town of Livingston, Idaho. Her husband unfortunately could not move in with her due to his job constraints, but was able to get job in Microsoft and move to close to her in Washington. In about 8 months of her stay in Livingston, Idaho, and completing required paperwork for Washington license, she was able to reunite with her husband in Washington. Vasudha ma'am continued her job with Premier Healthcare Company in Seattle. After 2 years of full-time employment as a lead physical therapist, she completed lymphedema certification, which was basically a new skill to manage swollen up body parts. While juggling with new motherhood experience and professional responsibilities, Vasudha ma'am enrolled in Doctors of Physical Therapy program after 5 years of clinical practice. Her focus during this program was to attain expertise in women health and restorative exercise. It was an intense program and required huge commitment and time and effort. After achieving doctorate, her expertise in her profession earned Vasudha ma'am a position as director of rehab in a prestigious healthcare organization in Seattle. She also became the marketing ambassador for her organization. Soon she was sought after expert to start up new rehab clinics from scratch. She also mentored many therapists and managers to achieve the perfect balance of quality care and productive work. Vasudha ma'am has trained many therapists and clinics all over Washington state, but her true passion was always one-to-one patient care. Her ideology around future healthcare is to not focus on medicine, but the human frame, proper diet, and in cause and prevention of illness. Due to the overwhelming response and request from her social media oriented health plan, Vasudha ma'am started gaining more expertise into skincare in addition to the physical therapy background. She truly believed that the skin is the mirror of our health. This journey, which she started as a disheartened H4 immigrant, is definitely a true transformation story of an acclaimed health and beauty specialist. Vasudha ma'am is an active member of American Physical Therapy Association. She has received many awards and recognition for her professional achievements. She recently gave up her management position to concentrate on her passion of writing and providing personal touch as a social health and wellness promoter. Currently, Vasudha ma'am is distinguished speaker at many healthcare facilities and also assisting many leading clinics to provide physical education, screens and update of plant care. She also works as for a non-profit organization for care of homeless elderly. Vasudha ma'am has recently started sharing her ideas and experiences in a blog called sudhasays.com, which circles around people, places, passion in life. Vasudha ma'am's message to other every other woman is it always seems impossible until it's done. Well, it was a very big introduction, and I guess this is just a short summary of what you have done over the period of time. So we are very blessed, honored, and very pleased to have you with us today. So a very warm welcome to you, ma'am, from both of us.
Thank you, and kudos to you to read all that. So thank you for having me.
Sure, ma'am. So, starting with today's topic, which we have is, as we had discussed, that it was a penetration of IT in healthcare sector. We understand that IT is one of the most important part of our lives in our day-to-day life in this regularly changing world. So, how has been IT being affecting in healthcare sector? What is the major role the IT is playing?
So, IT is the straw that stirred the drink. That's what I say. It's almost without that, it's all there, but nothing will make sense. So one of the main transition which I faced after coming to US was that the healthcare was, that was back in 2004, was very successfully managed by various software companies here. There are 2 or 3 major programs in US that takes care of the entire healthcare data around the country, and they like to keep it very uniform here. So the typical role of the IT use of the IT is those softwares which have been created, which can make the users, which is the healthcare professionals, their life more organized, and they can spend more time with the patient care, more efficient and quality time with the patient care. But it also, the another reason IT was so much heavily adapted in healthcare was for the reimbursement, because the US healthcare essentially is, controlled by insurance companies. So to have a manageable way to, have patient data, but also to be able to provide them with accurate bills. So that was the role of the softwares which were created in the healthcare industry.
So, ma'am, as you told the basics of what IT does in healthcare with the use of software and all, are there different levels of IT which is used in healthcare sector?
Yes, so healthcare is a very broad term. It's almost like saying human race. There are so many type of human beings. There are so many types of, variety. There are kids. There are elderly. So same way, healthcare is a very broad term. So when somebody, for example, falls and break his hip, they may need immediate medical attention and they need to go to the hospital. So that is one level of care, the initial level, which is called acute care in United States. So that's like the first level where you go to emergency, you get admitted in a hospital, you have major surgeries. So that is more like an emergency basis. That level of care where you just need immediate attention, immediate medical attention. After you have been stabilized, the goal of the acute care is to transition you to a lesser level of care, because they need to, keep the rooms available. Not only that, for the reimbursement purpose also, you can't keep, in US there is no way doctors can tell patients to stay longer, because everything is very much managed by insurance. They are going to look at everything. Those are like the sharks. Nothing leaves their sight. So that is another reason that always the goal is to transition them to lower level of care. So that would be the transitional care. So for example, if the surgery is done and the patient is stabilized, the patient will say, well, I still can't get up, I still can't walk. And the doctor will say, you don't need to be in a hospital bed to recover. You can go to a transitional care center. So that's a lower level of care. Sometimes, care is provided at the long-term care level, where somebody might need like a long, maybe 6 to 8 months of recovery period, in case of some elderlies, some chronic conditions. So that is a long-term care bed, and that's the third level of care. And the fourth level is the home health. So some patients might just go home directly from the hospital, like that happens a lot in India. Like if you were in hospital for a couple of days, you're not going to go to an institution because you're like, well, I have 10 people to take care of me. So the home health is another option which is available in US. I have worked in the home health industry too. So home health is where the healthcare professional would come to your home, but that's like the fourth level of care. So those different levels of care are there, and every level of care has a goal, which is to be answerable to the insurance why they are providing that care. That's the number one goal the software is doing, because everything is related to reimbursement. So like for cricket, it is said, well, play defensively. For some players, they say. So same way here, same for driving. You say just drive defensively. Same way is the healthcare reimbursement. It is done defensively. That the documentation has to be done in a way that they are just justifying themselves each and every day why they are providing that care. And to be able to justify that level of care, you need a highly specialized software to prove those justifications. So that's like the different levels of care, but with the same goal to justify why the treatment was provided. So connected to the patient condition, paint the whole picture, and then provide a bill to the insurance.
So, ma'am, as you mentioned that there are different levels in the healthcare, and there are uh, there are various types, and it's completely different how it works in US than how it works in India. So, what is your expertise? What do you majorly handle?
So I am currently a case manager in a major insurance company. By case manager, I mean I am the one who decides how much authorization should be provided. Authorization as in insurance, how much of their medical stay is authorized. So sometimes I'm the bearer of the bad news, but my goal is like a patient advocate, because I am not an accountant. I am a medical professional reviewing the case. So my role is to look at the data provided by the software, which will give me an accurate picture of the patient. How that data is interpreted, I will share with you shortly. But, you know, I can see up to like 20 patients in a day. And how do I do that? That's thanks to the software. Lets me, filter out things which I need to see quickly, rather than read like the entire story. So we all are the healthcare industry in United States is extremely busy, extremely understaffed. And the only way we can stay operative is by using good tools, by using, our laptops, our computers with those quality softwares we have, which will be able to give us a great picture. And then what I do is I tell the insurance company. So I am like a middle person. I do not belong to insurance company, but I am doing a case management for them so that they can understand what's going on with the patient. So, so that, yeah, I hope I was able to explain myself. So that's my role. So I heavily, use the IT, almost like, I breathe IT in healthcare, you can say.
So, ma'am, as you said, you have almost 20 cases a day, which is very difficult to manage. So, how much easy it is for you to manage these cases and help the people claim their insurances?
Um, it's, see, when you are managing a case is not like, you have to see a patient. I hardly see my patients. I am not going in their room and talking to them. I don't do that. I am relying heavily on the data. I sometimes do a phone call with a patient, but I'm heavily relying on the data and accuracy of the data. So my role is not only to enter the data from the files, from the records which I receive from different, professionals, like maybe X-ray people send me some record, maybe, an MD send me some record. I'll review those, and then a I form like, a picture which I match with a criteria. Like, I gave you an example of a person who broke his hip, you know. Now, if that person needed surgery right after the hip was broken, then that person is going to need more money to get the surgery done. So I look into what was the kind of surgery performed. But see, a unhealthy active person getting surgery versus like an 80-year-old person getting surgery, those are two different things. So, I cannot be like just blindly approving money or reimbursement or authorize them, because their needs are going to be different, their recovery time is going to be different. So the software here has made tools. The tool I use is called a predict tool. So they have made tools which will predict that for this patient in this set of circumstances, with this age, with this diagnosis, with this other, comorbidities, like other conditions present or not present, will need like maybe about a 15-day recovery time. And now, I don't go blindly by what computer is telling me. Of course, I'm going to pick up a phone and talk to the patient too, how good they are doing. There could be always something which sometimes we miss in the data. So that error, to account for that error, I try to take extra steps and call, and that's why I say I'm a patient advocate. So I don't just blindly look at the data. Data is definitely a tool helping me make a decision, but but the real decisions lie in using our intelligence. We have to still use our intelligence. So how I am able to make that, do that, is by being very proficient in using the software. If I do not have skills to use the software, if I'm just blindly entering it and not interpreting the results, I still have to interpret the results. And the only way I can do it is by, by being more proficient in the system. So that's one way. That's why the case management job is only offered to very, very experienced people. It's not offered to everybody. Like beginners don't get the case management jobs. And at the same time, it's also like, how your comfort level, can you handle it? So I think this is a very unique position, and I'm very comfortable doing this.
Definitely, ma'am. You gave a great insight on what job do you do and how it is being done. Because reimbursement is something which is very important, because patients or any people around the world feel that if there is insurance, everything will be covered and every amount will be refunded to us because we have got an insurance. And I guess many times there must be an argument also, there must be a disagreement with your patients also, wherein they must be saying ki, they should get more amount of money than what you have told for the reimbursement. So before moving ahead, we have a comment from Rahul Tiwari. He says that sorry for interruption, but one point I want to raise that the issue raise the issue that no one raises. People here, people in India should not simply ape whatever is being done in West in the name of technology. There are lots of there are a lot of that's difference here, and I always see in software industry who are bent on copying everything that is being done in the West. So yeah, I completely understand on the point that these are two different nations. One is a nation which is completely developed, and India is developing. India is a developing nation. So definitely there are differences on differences of idea. So one question, ma'am, arises from this question is, what do you think, as basically you are from India, you are an Indian, you are a religious person, so according to you, what do you think, ma'am, what are the things that need to be done in India in order to improve or imply these things in India, if there is any chance of implying this?
Yeah, well, thank you, Rahul Tiwari ji, for that question. I'm happy to answer it. I love that people, participate in discussions. Um, to be very frank, I I don't think it is very prudent for any nation to copy others, because uh, what set of circumstances one country has, the other country would not have. Here, the infrastructure of US, I was sharing it with the hosts, both the hosts the other day, is based on insurance. It's hardly out of pocket. It's everything is insurance. In India, for example, when I visit a couple of years ago, my son was about an year old, and he got sick. He had the flu. The cost of going to a doctor and getting him treated was only 1,000 rupees. When the same condition happened here in US, his medical expenses were $5,000. It's the same condition, it's the same treatment. Why in India I paid 1,000 rupees and the doctor was very happy to see me and in fact did extra for me. Um, and in US, I had to call for an appointment. Doctor didn't even have time for me. It was very difficult to get in. They just wanted to avoid it. They triage a patient. They'll first give you a call and even see if you should even come in because they are so busy. Um, and then finally, I got an appointment. They said you're just being worried for nothing. Your son doesn't need and still it was a $5,000 bill. So you have to understand the infrastructure of two countries. This is a great example. We are the same human being. Everything is same, but the infrastructure is so different that if US copies India or India copies US, both would, lose a lot of caliber, a lot of, I would say, business in the way the things are running. Here the things are run on a very capitalistic manner. It's a very capitalistic society. Now in India, which is, it's a great country. I'm from India, and we are still a developing nation. We have come so far. If we start copying without taking care of the basics, what will happen is we are going to create bigger problems for us. So every situation has to be analyzed. Why we are doing that? When I go home, my mom says all the time, "ये तो US बन गया है." Like my mom always says that, and I laugh at her. I say, "And you think it's a good thing? It's not a good thing, because the situations in India is way different from situation in US. And maybe sometimes what you have is better. You won't even know it." So, so I think you are right in saying that we shouldn't copy. I always say, go to basics, see what you need, analyze the situation, and act accordingly. Um, I won't say US is perfect. In fact, the healthcare system in US is very messed up. I don't know if you have read articles, you know, but that's why I went to more of the social side of the healthcare, because I was I was feeling like, you know, I was constrained in what I could do because of the amount of, you know, the way insurance was controlling everything, you know, the way your infrastructure was controlling everything. Like in India, I was the same physical therapist and I could do like 10 different things and go home peacefully. But that couldn't happen here. So, long story short, I don't think it is a very good approach if any professional is trying to copy the league of other countries. You know, any student who is graduating from the college, their first approach should be, you know, be a first, be original. If you cannot be original, whole life, you're going to lose the immense talent and potential you have, because you are just trying to be someone else and you're losing what you have. So be original, just, you know, analyze your situation, and never stop yourself from questioning. Whatever happens, do not take it for granted what you have. When I came to US, that time I was very excited. You know, I was a newly married girl. I was very excited, but like in a month, I was missing India like anything. I didn't know because you know, unless I came out of the country, I didn't know what you know, how important those things were. So you I think India has great potential, always had best of the minds. You know, I really feel the challenges of India are way beyond you know, what other countries face nowadays. And you know, we definitely need to focus on our immediate you know, local community, because that would be the true picture of what you need. Well, if you keep looking outside, your home would never be sufficed. So that's an answer I can give you.
That was a very good answer explaining the major differences between the two countries. And ma'am, you very rightly said that it is very important to be original, because that's the key to success, even for an individual as well as a country. So moving ahead, as you explained earlier, what are the different levels in healthcare? I would request you to throw some light on what are the different levels of care cases.
Yes, I think that's a great question. Definitely. Like, you know, I mentioned every level of care. Yes, there is always a common goal in using a software to justify why you are providing that care. We call it here justification of skilled services. So every software would have that column somewhere in their documentation, which is, you know, meant for insurance. So it's called justification of skill service. But, you know, as I said, every level of care would depend on the urgency of the situation. So for example, if somebody is in hospital, that's a more emergency situation. You know, they need emergent care, right away care. So they have to document why the patient could not go to an outpatient clinic. Like, you know, I have seen it. This is another example. I can show you the contrast between two countries. Like in India, because, you know, it's not insurance based. I mean, maybe now more insurances are coming, but at least till the time I was there, it was out of pocket. You know, my father has always paid out of pocket to the doctors, whatever their fees was. So like during the night, my father felt that he was having nausea. He felt like vomiting. My dad was a heart patient and my mom got very worried, although there was not like any sign of worry except that he was feeling nausea. And my mom took him immediately to hospital, and hospital took him and admitted him and kept him for 10 days. Now, if the same scenario happened here, they would not even allow you in the emergency unless they see they are able to record some objective way to determine you need emergency. So when you go to emergency, first thing they'll do is they won't even let you enter the door. First thing, they'll take your temperature, your heart rate, your blood pressure. They'll take all your vitals because they have to justify their service. They can't just take any person like that. So that is, everything, every level of care has to have objective measurements available. You just can't say that patient was very sick. What does very sick mean? Explain it in data. What does very sick mean? Does very sick mean that the blood pressure was beyond 150 mmHg? Does very sick mean that the heart rate was beyond 140 beats per minute? Does very sick means that he had 105-degree fever? What is very sick? They'll ask you these questions. So every level of care has to justify with this objective data. So, the hospitals will do the vital signs measurements, and they will also, depending on, for example, if somebody went with a broken limb fracture, was there swelling available? What was even the pain is rated, on a scale of 1 to 10. Just tell us. So unless so people here have become smarter, and they'll always say, I have 10 by 10 pain, and insurance knows right away that that's fake. Nobody can have 10 by 10 pain unless you're delivering a baby. So so what I'm trying to say is that every level will have some objective measurements to prove the level of care provided was justified. So that's one thing which softwares would do, and software system would be laid out in a way that even like the least educated person can look what values they need and enter that by recording. So that's the whole usefulness of having a software in different settings.
Definitely, ma'am. So as you mentioned that there are different type of cases, and there is a different way of expressing to doctors basically how are you feeling about, like every patient has his way of expressing to it. So you being into medical field, ma'am, I completely understand that you have no you don't go to clinics, you don't visit your patients, but I just wanted to ask you how much time has it happened with you that people come to you for a solution? Ki, ma'am, this is the problem I'm facing. Please tell me some solution. Or is there any such cases wherein people come to you for a solution of their of some problem they are facing?
Well, first of all, I have very much gone to clinic. I was a clinician. I don't know, you just read my bio. I've provided direct patient care until the start of COVID because of COVID, I took the work from home job because I wanted to keep my family safe, and I got this offer and I took it. If I didn't have the offer, I would still be treating patients. And honestly, I love that. Once a doctor, always a doctor. The people will always come to you. So, no matter you say I'm practicing or not practicing. And I have 20 years of experience in direct patient care. I have seen patient until February this year, treated them. And after that, I started the case management. So what happens when a patient comes in an outpatient clinic, for example, like in India, typically, for example, if somebody gets up in the morning and say, oh my God, my neck is so tight today. I can barely move my neck. And they'll say, oh, well, why don't you go to the doctor? And, they'll say, well, I have, just for fun, I did that. I said, okay, let me see what will happen now versus when I was there. And things have hardly changed. So you go to the doctor, they'll just look at you. Some doctors don't even want to touch you. And they will, maybe ask their assistant to help them. And they will, prescribe you something like a painkiller or something. They'll tell you to do physical therapy. You go to the physical therapist gym. Somebody will say, lie down on the bed, and they'll provide some, a modality treatment to you, and they'll send you home. Well, the problem with that patient care and the patient care we provide, there is a huge contrast here. The reason is that the care which I just mentioned to you, that care cannot be quantified. If it cannot be measured, if it cannot be recorded, it is not called skilled. And why it can't be quantified? Because no objective measurements were done. If the doctor has not touched you or used his assistant, or doctor has not done all the set of vitals, all the examination, because they don't need to fill those forms, right? So technically, even if they don't do all that and ask you like ₹1,000 fee, I don't know what the fee is nowadays, but you'll be like, yeah, you'll be gladly giving it to you. But actually, in US standards, they call it a blue collar care. Blue collar care is like you haven't hardly examined the patient. So unless you have done the whole examination and have provided a proof of that, it's not called quality care. So the direct patient care, that's what it means here. If a patient comes to me per se in a clinic with a neck pain, my first objective is to do the whole evaluation. So the software will not even let me start the patient case unless I've entered the evaluation. So for evaluation, I'll have like a 4-page form. I have to fill that 4-page form. So, it's called complete physical examination. Now neck pain, I can right now lecture you that there are like 40 different causes of neck pain. How do I know? I have to do a differential diagnosis. Why this patient is saying he has neck pain? Was it just he slept funny? Does he have a slip disc? Does he have a herniated disc? Does he have any scoliosis developing? Does he have any, neuropathy going on in the body? Does he have any unknown injuries which are flaring up? So they just list. So I have to ask. I have to find out. I have to provide him with the diagnosis. The patient will always say, I have a neck pain, but I am the one who has to give them the answer. So that's the way the examinations are conducted here, with the initial problem of the patient. The whole thorough examination would have, first of all, the demographic, where we will enter patient name, patient age, patient date of birth. We just can't say so and so. We have to we have to really explain the patient like to a blind person who has not seen the patient. And that blind person would be the insurance person, which is me, because I have really not seen the person. So that is how the direct patient care looks like. So after entering, then I have to ask question on their functional level. What were you doing before this happened? Were you a very active person? Were you like sedentary? Were you bedridden? Were you lifting heavy weights? What was your lifestyle? Those kind of question, which is called prior level of function. And then maybe I'll have some answers there, that what's going on with him, why this pain occurred. Then we'll come to, after that is past medical history. Some patients have a medical history of unstable spine. So unless I have looked thoroughly in the history, I will not be able to make an accurate idea. The fourth thing would be an objective assessment, where I will take the objective measurements of the range in the neck. So today you came with so much pain. So, everything is quantified. Like there are standard set of values that normal range of the neck is this much degree and this much degree, and neck can have movement in these directions. So I have to measure and compare it with the normal set of values and figure out how good or bad it is today, so that at least I have a baseline on the first day. So I can make a determination like 5 days later, I have provided the treatment. Like, in India, you must have seen people say a lot, I have gone to doctor for 2 months, no result. Okay, what does no result mean? Has doctor measured your results? Has doctor seen there were no results? Like, has they compared from first day to 10 day? Like, so how would you know that unless you have some sort of information, objective information to compare? And, human body is like a machine. If you really want to measure, you can measure literally everything. So that's how the examination is conducted here, the initial evaluation. And then after evaluation, we pick a ICD code, which is a diagnosis code. Now, if I don't pick a diagnosis code, how much money you think I'm going to make? Any guess? What's your guess if I don't pick a diagnosis code?
We have literally no idea about it, so we can't help you out.
$0.
You can give us options and we can select from those.
There are no options, $0, no diagnosis, no reimbursement. So that's why I'm trying to say that, that's a huge difference in approach. You just can't call it a neck pain and call it good. You have to define what is happening with the neck. And you can only define it once you have done that examination, once you have asked that question. And that's only you can pick up a correct ICD code. Now, if the ICD code is not picked up, you can't bill insurance. So that's why doctors here spend so much time on examination, touching the patient, trying to take measurements, assessing the patient, thorough assessment, because their reimbursement depends on that. The treatment is the another part, but the first part is the accurate diagnosis. And if they have not diagnosed the patient accurately, they'll lose money, because if they just call it a neck pain, they'll be paid peanuts. They'll hardly get any money. So I hope I was able to explain how the interface with the patient looks like here.
Yes, ma'am, you very well explained it. And moving ahead with the further session, I would like to ask you, which software is used to maintain data in the healthcare sector in US? You mentioned that software. There is one software which you use. So, which one is that? Which is that software?
So every level will have their own different, because as I said, every level would have a different sort of layout, because their goal is to provide the reasoning, but you can only generate the reasoning if you are accurately capturing the patient condition. And patient condition would vary in every level. The hospital level of care would be very emergent. The clinic level of care would be less emergency. You just go once you have to go. It's like not an emergency kind of a situation. So there are several softwares. The one which is widely used in the outpatient clinic is called Rehab Optima. Rehab Optima, especially for any kind of nursing or therapy needs. Even doctors, MDs are using Rehab Optima nowadays. The home health is using Oasis software. The Oasis software is a standard software throughout the United States. Like, every company, any home health agency would use the same software. So some places it's standardized, some places it's not. It just depends on the level of care. Like home health is standardized, but outpatient, we have Rehab Optima. We have 2 or 3 more different ones which are less popular but still used. Then we have the one which I'm using for case management. It's called Navi Predict, because I am predicting outcomes. So the use of my software is with a different goal. So I mean, yeah, there are few. It's not like a whole lot, because creating a software for US is almost writing like a story of Mahabharat. It's very 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 detailed, and it's very I would say specific, with lots and lots and lots of different segments, and that's one of the most common one is the Rehab Optima.
Definitely, ma'am. So as you mentioned that you have worked in clinic, and currently you have associated with case management. So my question comes around is like you must have seen n number of patients. You must have seen different types of patients. What has been your toughest case till date? Like there's a very vast experience with you. So what has been your toughest case which you have faced, wherein it was you felt like this is something which you haven't experienced over the life yet, over your working experience?
I think I would tweak your question a little bit. It's not so much as tough. It's like I would say more of a challenge. Challenge. I would say there has been some really challenging cases. In fact, I face challenging cases almost on a daily basis. Medical is just one part. in our bio session today, you mentioned, so I focus on the social aspect for health. Now, one of the problem in United States, and this kind of ties into Rahul Tiwari ji's question, is also that the society is so different in two countries. Here the social structure is like it depends on institutionalization of elderly. They, if either they have to live alone, it's a very sad old old age period, which I've seen. I have worked with elderly for 20 years here, and every day was a challenge, because what I saw I never saw in my life before. I've seen, like, people with dementia living alone. They can't even make out what day of the week it is. They don't even remember sometimes their own name, and they live alone, and that's a challenge. As as a person providing them the care, I'm always like, I wish somebody was there to talk to. This patient can answer my question, and there was no one. There's not even like a number I can call. And that's a challenge, but that's also a social challenge. The society is like that, and it is really up to me to find that backup for that person, because I am the one who can accurately determine what's wrong. People will come in contact with a person would not know what is wrong. They might just call him lunatic, but I can determine, because I am educated and I'm providing care, that I can make a determination that this person is not fit to live alone. They should be under somebody's care, or they should be in a place where they can be safe. So those are challenges related to the social setup, and those are more common here. I mean, we have great advancement, medical advancement. I mean, you have literally n number of options in providing treatment. But dementia, mental problem, there is no cure for that. There is no cure for dementia. And here, the number of dementia cases, the number of elderly dementia cases is way too high than I have ever experienced. So, I'm sorry. So seeing a patient with mental health living alone in an old age has been my biggest challenge. It still tends to be. It breaks my heart on a daily basis. It's more frequent than I'm telling you, and I feel like if I am not there, there is no one to take care of the situation. So oftentimes I am the one. So every healthcare setting would have a social worker. Now, social worker, typically in India, we think like a general term. Here, the social worker is actually a certified person. It's an actual degree. You go to college and become social worker. You just can't just call yourself social worker. You have to have a license. So there are licensed social workers who are present. So I'll contact them. So, here the approach of treatment is called interdisciplinary approach. So it's not just, I am not be all and end all. Like, I'm a doctor and I am God. It doesn't happen like that. I have to talk to other people. I have to tell them, I have to take their help. And I have to be like, hey, I have a patient who can't even tell me it's day or night. I need social workers' help to help me form like a plan for this patient so that they can be safe in the community, right? To provide them with the support and the backup. They'll just starve to death otherwise. So these are the things which are challenged because of the social setups. And but we are, as I said, software is one thing. We have to still use our intelligence. We have to use our grit and humor to go with every case every day.
Rightly said, ma'am. And for a person in medical field, it is really tough, even physically and also emotionally. And moving ahead, we have a question in comment section from our engineering college principal, Shrikant Kalurkar sir. What is the role of alternative therapy in USA?
I don't think I understand the question. I don't know what they are referring to alternative therapy. Are they referring to alternative medicine? Like, um, I don't know. I don't know what alternative therapy means. And it could be just we are using a different term here. I mean, if they can clarify me, do they mean alternative medicine? Like, we do have, we call them, naturopath here, the one who provide alternative treatments. I don't know if they mean by that. So, okay, he said yes. So, like alternative medicine, it is becoming very popular. When I came to US, I was very surprised. There was a crisis called opioid crisis. I don't know if you have heard about that. You know what an opioid crisis is? Heavy dependence on pain medication. Opioids are the pain medications. Heavy dependence, like crazy dependence on pain medication. Like
Google name also.
people would rob like pharmacies to hoard pain medications. And that would happen like at gunpoint. And I was like, wow, my goodness, must be like something very, very serious. So there was like uh, that was a big time. The opioid crisis in United States lasted for a long time, and people were so dependent on medication. So the whole focus of the healthcare changed. So the whole holistic approach and the naturopaths came in. So in India, the ones we say like Ayurvedic medicine, here it's called the naturopathy. So naturopathy physicians came into more visibility, more naturopathic training centers and colleges were open, and now we have so many, they call it wellness clinics. Now we have so many. Homeopathy is gaining so much popularity here because now people realize how harmful these, which we already know in India. So people try to do Ayurvedic, homeopathy here. It happened now after that crisis happened. So it's becoming very, very popular. In fact, almost every patient I talk to tell me the same thing. I want to stay away from pain medications because everybody knows they are very they form dependence very easily. People become dependent on pain medication very regularly, and they don't even realize it until it's too late. So now people are following the path of alternative medicine a whole lot, and that's why people like me are so busy, because we are the ones who work on the rehab. So it's becoming very popular in US.
Definitely, ma'am. And as you mentioned that the alternatives are pretty much required, and India has the India has that Ayurvedic thing, and as you told that you people believe in naturopathy. So basically, ma'am, as you previously mentioned that there was a question from Sneha who said that there is a particular software and different level uses different level of software. Different level of healthcare uses different level of software. So if is there any possibility that you can share your screen and show us what kind of software you use, a demo run of how basically you store the data and how you manage it?
I can try with all the technical glitches I've faced today. I am curious how it's gonna go. I can try. Give me just a second. You can ask me another question while I'm pulling that up.
Surely, ma'am, surely. So, ma'am, basically, what is the major difference you feel like, apart from the insurance thing and apart from the costing, what is the major difference you feel being treated in India and being treated in USA? I'm pretty sure you must be treated at both the places. So, what is the major difference you feel amongst the two countries?
Well, it's the major difference I feel is the focus on more objective data, which is very important. The focus on accurate diagnosis. We are not using vague terms here. Like, when I go back home, I can't really find out what is going on. Like, my mom will say, oh, that person died because of, low oxygen. What does that mean? you know Low oxygen was like, what what caused low oxygen? How can somebody die of low oxygen unless they have a condition? I mean, there can be low oxygen in this room, but that doesn't mean that, I'll die right away unless I have a condition. So why? So the focus, the way the problems are, the medical cases are classified, the way the medical cases are analyzed, that way, that approach is very night and day. I gave you the example of neck pain. I said it, unless you have given an answer to the person. So when you are going to a doctor and saying neck pain, unless doctor has really worked hard in giving you an answer, really not much was done for you, except that they just wanted to take your money and give you a pill, which is okay, but that's not the answer to your pain. That you will come back again and say, I still have pain. It only goes away when I take, because the root cause of the pain was not determined. The other thing is the accountability. I feel like the medical field in India is not held as accountable as they should be. And one of the reason, I mean, really, in today's days also, like, doctor ne bol diya to bas. Why? Why it is like that? Why you have the right to know? Here we call it a patient-centered approach. You should, the focus should be patient. The focus should be, what can this patient do to get them better? In India, the focus is more on what doctor can do to make you better. So those two approaches are way too different. When you were reading my bio, one of the thing, the restorative things, when I treat somebody, I I want to train them. I am not just saying, come to me when you have a problem. I'm saying, anytime you have a problem, this is a solution, right? So then my focus is patient centered. My focus is not like I need to treat the problem. My focus is, I need to empower you, what you need to do in case this problem arises. So, and the amount of education they provide to the patient, it's outstanding. I used to go out with books to give to patients, and I used to help them understand that. So here, a lot of patient handout is made in patient understandable language, so which patient can understand, and interpret it, so that they are really more in control of the situation. They know always what is going on. Like, if you ask a patient, they're so good. Like here, if I ask a patient, okay, tell me what medications you are, even if they are taking 10 medications, they'll know the name, they'll know the dosage, and they'll tell me how many times a day they take. And I'm amazed. I'm like, when I ask my mommy which medicine, she'll say, I take the red one, I take the green. So because the doctor never paid enough time to explain her why that medication was given, what is the role, and she never took that initiative too. So it's like, it's both ways. So that's the huge difference in ideology, philosophy. Here the patients want to take charge of themselves. In India, it's more like, I am here, you take care of me. So the way the whole approach is on the both sides of the table, it's much different. And I feel like that's what I tell my family also all the time. I say, you need to be in charge of your health. No doctor can cure you. You need to be in charge of your health. You need to understand, ask questions, what you can do. And that happens here, because there are bills, there are unavoidable bills. Everybody wants to avoid those bills because there's a huge penalty. Going to a doctor is expensive. People would rather not go to a doctor here. That's another sad thing. But at the same time, they take more initiative in keeping themselves healthy. So
Definitely, ma'am. And I again, there comes a point that people there comes a point of education. Like the people in USA, though we love our country, and there is no bad thing I want to say about the country, but there is a difference of education. People over here are not that much educated, wherein they can diagnose or they can express what they are feeling to a doctor. Wherein when you come to USA or any other country, they can easily express themselves. And I don't think so that it's a problem of India. It's basically a problem entire Asian country faces, that they're not able to express what they're feeling to the doctor, and it becomes very difficult for the doctor. And at the end of the day, doctor is at stake because डॉक्टर को नहीं समझा कि आपने क्या बोला है, and then what we do is we blame doctor कि डॉक्टर ने the doctor had given me a wrong medication and because of him my situation has worsened. So that's also
That
what.
is one thing, but yeah, in also the medical field, the other one I mentioned was that it's more focused on what doctor can do. You know, they always look at what they can offer, what they can do. Here, the focus is always on what I can give to the patient so they can know about this more, rather than coming to me all the time. So, I mean, and again, it's not bad mouthing. It's like learning from each other, right? I would, how would I learn unless I know what I need to learn? I tell my family all the time. And you know, I have elderly parents. I tell them same thing. I say, you have to understand the doctor is there to help you. The doctor should not be there to scare you. So try to ask questions, try to understand what's going on, and don't worry, take extra time in understanding the treatment. If you don't understand the treatment and you just think that, you know, everything will be fine, you will not know what is going on. So you have to do that, and the focus has to always be on wellness. अपने आप को ठीक रखना. You know, this just how we are raised. It's also that, you know, just in general, my thinking changed heavily in past 16 years I'm here, because from an immigrant I became like a professional, and I had to provide care to American people, and I had to understand life through their eyes. How, and providing care is not easy. So providing care, you have to understand A to Z of a person. So that is one thing I say, that learning is very important. I learned a lot from, you know, I brought my Indian values here, but I learned a lot from, you know, where I found the deficiencies. So that's my goal, to present that, you know, we have so much scope of improvement, you know, in what we do to make our, you know, health industry stronger.
Sure, ma'am. Sure. So I hope your the issue has been solved of the software. Yet you're working on it.
I was carried away.
Okay. Okay. Okay.
I can't, yeah, I can't see that slide. I don't know what happened. I don't know. Today is for some reason, they're just, okay, hold on. I found some images I can share. Okay, let me share the screen. Yeah, today is one of the very interesting day. I have never experienced these challenges before. Let me share the slides. Okay, good. The only thing is that I know you like it to be, yeah, thank God I was able to make it bigger for you. Let me know once you can see it.
Yes, ma'am. We can see it.
Okay. Is it big enough? Okay.
Yes. Yes.
So this is the typical Rehab Optima program, which I was trying to mention, how it looks like. You see on one side, we have a panel of each and every patient who is receiving treatment in your center. So you see TX. TX means these are the active patients who are receiving treatment. So for example, if somebody walks in my room and say, Andrea Beasley, is she receiving treatment? Has she started receiving treatment? I'll go to her name and I'll highlight and I'll see there is a green ball. It doesn't say treatment. So that means she's being evaluated right now. So I'll know right away what's going on. I don't have to call 10 people to tell the person asking me question what's going on. So I'll say, well, this person is being evaluated. But if somebody say, Jennifer Bass, is she receiving treatment? I'll say, yeah, Miss Jennifer Bass is receiving treatment. You know, it looks like she's green and she's receiving. Now, see, some treatments are reflected as like, so this is how it all saves time, because, you know, the more proficient you get in the software, the more better your eyes can read what you're seeing on the screen. So now, for example, the yellow ones. So what they do is they try to highlight different colors to explain the different payer sources. So the green one is Medicare. They have color coded. So every patient who has a Medicare payer source would look green. But if somebody has a managed plan, an insurance plan, they'll appear yellow. If somebody has, like a Medicaid plan, which is a state, they don't have money, the government has to pay for them, would be black. So I will know right away, like I don't even have to open 10 tabs to, if like, my supervisor walks in and say, oh, by the way, do you know, I just saw Miss Kelly. Do you know if she has Medicare? I'll say, yeah, she has Medicare. So, that's the purpose of software. Saves you so much time. It makes you so better organized. Not only I have great information just from name and TX, and I can answer so many questions. Then you go, like, you see this tab on the top, new patient. Anytime any patient is not on the list, they walk in the clinic, we have to add them. So you see there's a plus sign. So it means that we'll click on that, and then the whole form will open, which we can enter. So a patient record would be, I can click, and each and every patient, their record would be here, and I can open that. But in case I just click on one patient, for example, we clicked on Andrea, then you see all, this is called the patient case. You see case manager. So this is all the patient case. So the different treatments they are getting would be under different tabs. Like, for example, you can see if they're getting PT, there is one tab. If they're getting OT, there is another tab. If they're getting speech, there is another tab. And you see they're all color coded, green, blue, purple. So, if you are a family member and you'll say, my mother, what treatments is she getting? I don't have to call 10 people, or I don't have to go into 10 different places. I can look in, oh, well, she's getting 3 treatments. She's gonna get these 3 treatments because I see the tabs. So that means they're gonna be working on her. And then another thing is, now, for example, if a physical therapist start the treatment, they will open their own tab. They're not going to go in the OT or speech tab. They will open their own tab. Now you see this evaluation, they'll hit edit, and they'll complete also. Remember I talked about the whole form where they have to fill out the whole form and reach a diagnosis and pick a ICD code so that they can get reimbursement. Sorry. So this is how they are going to be entering the data depending on what they are providing. So all the medical professionals in the chart can go and look at what other people are doing without even talking to them. I don't even have to ask my colleagues what you're doing. I can just read everything. But at the same time, I can do my own work in my own tab if I just want to focus on myself. Then the date range is here. Every time an episode of the care is there, like, then you will know exactly when was the first day she started receiving treatment. So, there is always the date range available. This is the place of residences, like the level of care. So she's getting at the skilled nursing facility. So that's what I was trying to say. Is it acute care? Is it a nursing home? Is it a clinic? So you see this even in a little space, they have packed so much data, and I don't even have to waste my time, and I can tell you like 2,000 things right away, just by looking at it. And then of course you end a case after you're done with the care. So to reflect, like, for example, if somebody asks you, is the patient still receiving treatment? Then you'll just say, hey, here it'll reflect differently as, the case ended. It'll start looking like a black ball. So like right now it's looking a green ball because she's being evaluated. It'll start looking like a black ball if the case has ended, like no more care is being provided. So very simple ways to organize big informations. And then evaluation forms are unique depending on what discipline is treating the person. If it's if it's an eye doctor, if it's a heart so their evaluation forms would be different. It's all unique. daily activity log. So when any medical professional comes in their clinic, their supervisor has given them a daily activity log. So without even talking to their supervisor in the morning, they can log in and they'll know exactly what patients they'll have by hitting on the daily activity log. So, you'll know, like if your husband says, oh, can you be home by 4 today? You'll say, okay, hold on, let me check. So you'll hit your daily activity log. Oh, no, I can't be. I have like patients till 6. So, it gives you so much information without even looking for it. It's right there. E-signatures, everything has to be signed. It's like a sworn statement. You can't make vague statements and go home and say, I've done my work. You have to sign what you're saying. You have to back it up. Labor log is a way, your workplaces make sure that you are recording your time. If you are hourly, most of the healthcare professionals are hourly wages here. So if you're starting like at 9 a.m. and taking a lunch at 12, so you log 9 to 12, you went for lunch. Because you're early, you don't get paid for lunch. But if you're salaried, then you just log in your standard 9 to 5 hours, whatever your supervisor have told you. It just depends. So, but that's how you monitor your hours worked. Appointment book is, what time you're seeing what patient. And assignment board is throughout the week. Like if you want to know, well, this patient I saw today, is he scheduled for another day in the week? They'll go to the assignment board and they can move the patient around. Hot list is the list of items which are pending to be completed by the professional. So they can hit that and, they'll know. And rest are like more supervisory things. Normal people don't use it. So it's just an idea what the software is trying to do. Not only it's giving you information about your day, it's giving you information about your patients. It's also giving you a lot of information about funding, how you're going to get paid for this patient. So there is just, it's just how it's like a lifeline, how your uh, daily activity, your patients, your care, everything is in one place. So that's the use of the software.
So, ma'am, what is the basic skeleton which any program uses?
So the basic skeleton, like, we just looked at it. They want to capture patient information, the demographic, which I was trying to show, the patient name, the patient date of birth, where the patient lives, then what payer source they have, all that basics information. Then the second thing they'll have is the past medical history. If you don't know what patient has, if they have, for example, if somebody says, well, I broke my hip, which is fine, but are you on blood thinners? Because if you're on blood thinners, you might develop hematoma because your blood is not going to clot easily. So, with a broken hip and a blood thinner, you are at an added risk. So unless I know the past medical history, I won't even know what the patient can suffer from, unless I have looked into it. So looking into the past medical history is always a basic skeleton. Looking into the prior level of function before the patient hip broke, what was patient doing? Was he a very active patient? Was it a sedentary patient? Was it a bedridden patient? Level of function. Uh, then, the objective assessment, which I've shared, everything needs to be measured because you have to provide the justification of services. So after the objective measurement, every system would have a way to score the diagnosis, which is called the ICD code. Every diagnosis is coded uniquely depending on the condition of the patient. Because I tried to trick you into that question, how much the reimbursement would be if you code neck pain? Zero. That doesn't answer anything, So have to be very accurate and defined what's going on. And after the coding, you need to have treatments. The treatment codes are called CPT codes. So what treatment you're providing, you have to pick the right code. You can't just say, I provided a lot of treatment. What was that lot of treatment? So you have to provide the code, you know. I provided med management. I provided, you know, pain management. Whatever you provided, you have to define the code and how you did it. I provided IV treatments, so IV treatments will have the code. Or, you know, if you provided radiation therapies, every treatment has a code. And after that, in the end would be outcomes. So unless you have measured your outcomes, how can you say? Everybody will say, I never had any benefit. Everybody would say, you know, because if they want to say, if they want to just be vague. But my outcomes will prove to people, well, I know what you're saying, but your body is telling me otherwise. You know, this is the initial data. This is today's data. This is predicted data. So outcome measurement, you know, the values we get from the system, the software will generate outcomes, because you cannot do treatments without goals. If you don't have any goal, your treatment are just like killing time. So so then the outcome assessment or measurement. So those are the basic framework of every software we are using in United States.
Surely, ma'am. So, ma'am, as you mentioned, there are two different things. There is one CPT code which you mentioned, and one is ICD code. So, I would request you to put some light on those. What are those two terms basically? What do they do? How much important role do those two terms play?
ICD coding is essentially for diagnosis. Now, somebody broke the hip doesn't really tell me anything. You know, hip has pelvic bones, hip has femur. What bone broke? Tell me, you know. So that is the role of ICD code. Did femur break? Did pelvis break? Was it broken, like shattered? Was it displaced? Was it not displaced? What happened? Which side it happened? Did it happen on the right? Did it happen on the left? So you can't just write on your piece of paper hip pain and treatment, this ointment, and send a person home. You have to tell me, how, you know, if this person has a broken hip, which bone at what degree has been fractured? And did it require operative treatment? If it required operative treatment, even if it's a hip fracture, it would be coded differently because it required operative treatment. If it did not require operative treatment, it just required bed rest and traction, it would be coded differently, because, you know, both are different and they are not the same treatments. So the coding is essentially tailored to what happened. And that is a role of the clinician, because only clinician can tell after assessing a patient what is going on, you know, what needs to be done. So you cannot be vague. You just cannot be vague. So that's the role of ICD, to define your diagnosis so that it is converted into a numeric value, which can be used for generating request for reimbursement. Otherwise, nobody would pay you because you didn't provide the code. So that's the purpose of the ICD code. But the CPT is the treatment. So as I said, you know, I just can't write a name of a tablet and call it a treatment. That's not treatment. That's okay. It's a tablet. What does it do? What is my goal with this? What am I trying to do with this? Is it even, I mean, I can write any tablet on a piece of paper. Does that justify reimbursement? You know, I have to explain, in this is the CPT code is a easily explainable numeric number which relates to the diagnosis. So for example, if you have a diagnosis of you know, open heart surgery, you cannot put a treatment of treadmill. This patient had an open heart surgery. How can you write treadmill in the treatment that I was using it? You know, it has to match your diagnosis. You know, you can put a treatment on, you know, cardiac rehab, and in cardiac rehab, you can explain this was my goal. You can still use a treadmill in cardiac rehab, but at least it's defined. You are, you are like, trying to have a goal that, by cardiac rehab, it means that you are trying to train the heart rate of a patient to, improve with activity. So makes sense. I'll pay you. But patient had an open heart surgery. I treated on treadmill. Really? Okay. So, so that's the role of the CPT code, to explain why the treatment is being provided and what is the goal of the treatment. So, I mean, you can write like 10 pages explaining because you want money, but nobody has time to read it. So they have to make it into a user-friendly code, which is a numeric number, which everybody will know. And we have those lists. We can pick and go to the list and see what that code signifies, and we'll know right away that why that was built. So that is the role of the CPT code, to justify the diagnosis based on treatment.
So, ma'am, how do you identify like who needs to be reimbursed? How much amount?
Yeah, so that's why we are heavily focusing on documentation. Documentation is the criteria. They always say in US, if it's not documented, it never happened. You can work all day, and at the end of the day, you can say, I worked so hard. You hardly filled a paper. Technically, you did zero work. So, and vice versa is true too. You can sit on your chair all day and you can say, I worked very hard, and you can write 10 pages. They'll believe you because it's documented. That's sad, but it's true. Uh, Documentation is really the essence of how you get reimbursed, because documentation is done on honor system. Honor system is like, I am a licensed. It's a regulated. Healthcare is heavily, I would say it's even more regulated than nuclear power plant. It's a very regulated industry. So healthcare, every professional is licensed. Even if an assistant of nurse is there, she has to be licensed. So your license can be revoked if you're doing malpractices. You can't just continue to do the same thing and you think, I'm going to get rich one day. No, no, no. People will report you right away. Your patients would report you right away, because the state has empowered them. If any malpractice is there, just say. Even if you have a doubt of it, just say, and there'll be heavy investigation. And so you are licensed, and B, I showed you everything you do is signed. So because you're a licensed clinician and you're also signing it, you better be able to stand for it if a judge calls you in the court. And how many times that happened? That happened a lot. Judge will call you in the court if there is even a slightest doubt that you did a malpractice, that you didn't work so hard than what your documentation said. So there are systems, there are checks and balances in place, but at the same time, the main criteria for any reimbursement is documentation, and documentation has to be accurate. And the only way it can be accurate is if you have used your heart and soul and filled it as accurately as possible, because if you have not done that, you're not going to get paid fairly. So that's how it happens.
Surely, ma'am, that was a great insight. So my basically we are done with most of our questions. So next question, as it's your birthday, and yesterday also when we discussed about that question, you told that that question makes you feel old, and being your birthday, it will definitely making you feel much older. But still, I'll resist myself to that question. That what would be your message to the students who are currently will be graduating soon, who are doing the masters, or the students who are in early ages of their medical life, and they are just starting with the medical journey with the clinics or hospitals or any other things. What would be your message to each and every one of us?
Good. That's a great question. Well, work on your vision. Spend time, vision. Like, um, don't just start running nowhere. We all do that sometimes. We are like so busy, but where are we getting? You know, so form your vision. Spend time in understanding what you visualize yourself doing 5 years from now. Have goals in your life, set goals in your life. If you have not spend time with your vision, if you have not, like, for me, I envisioned myself working in initially I was denied license for 3 years, but my vision was I will be in healthcare, I'll be a leader in healthcare. and I worked on it. So unless you have a vision, unless you are able to be, able to understand um, what is the purpose of your act, and the secondly, to set goals. If you have not done that, then you might be working very hard, you might be facing a lot of challenges, but you're not going to get the results you need, which you want. So, like Simon Snake, the famous motivational speaker, says, find your why. Start, find your why. So that's what the message I'm going to say to everybody. And don't copy whys from others, find your why. Spend time, is find your why, look, work on your vision. Even if you have to take a day off and it look funny that you're thinking, just thinking, it's okay, do that. It's not funny. You have to understand what you want in 5 years from now, and then you work on it. And I think 5 years is a great target, frankly. I like, my mom always used to ask me long term goals. Once you become a mother, and I'm like, no, 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 no. I can't think so far. So I always, focus on, vision. What is the big picture, so that everything will fit what I'm trying to do. So I think that's all I have to say.
Thank you so much, ma'am, for your message, and definitely it will be very helpful for us. So I guess we are done with our today's question, and definitely we'll be keeping some of the questions in our bank so that we can invite you again on this platform, and we can have another interactive session with you. Also, one thing which I failed to mention during her introduction, that she's also our education partner for Atharva Institute of Management Studies. She's also our education partner for IEIC, Innovation, Entrepreneurship and Incubation Center, and we are very lucky for that too. And I'm very much sorry that I missed out on that important information. Now I would request Sneha to proceed ahead with the vote of thanks.
Thank you, Shivang. Firstly, I would like to thank Dr. Vasudha Sharma for taking out time from her busy schedule and providing us with this amazing and very informative session. I would like to convey my sincere gratitude to Sri Sunil Rani, Executive President, Atharva Group, for providing us various platforms like this one for interaction. Miss Varsha Rane ma'am, Miss Pallavi Rane, Trustee Atharva Group, Dr. R.G. Ratnawat, Director AIMS, for giving us such a great platform to interact with people and help enhance our knowledge, and also guiding us in all the events and giving his knowledge to bring the best from us. Dr. Shubhilal Agarwal, Director IQAC AIMS, for overall coordination. Last but not the least, I thank the torch bearers, our student coordinators, Mr. Piyush Chaudhary for designing flyers and helping in digital marketing, and Mr. Shivang Sharma for being such an amazing co-host. Without their help and support, this event wouldn't have been possible. Their hard work and willingness to give one and all a pleasant experience has made this program a grand success. We wish to see you all in the next episode of IT Talks with the same enthusiasm. Thank you and have a nice day.
Thank you so much, Sneha. And you also have been an amazing co-host for me, and I've been very lucky that I have been co-hosting with you. And also thank you, Vasudha ma'am, for joining us and giving us your precious knowledge and sharing your experience, and giving us an entirely new dimension to what healthcare sector is and how it has been working with the help of IT.
Thank you so much for having me. You both are very gracious hosts, and thank you, Atharva School of Management, for this opportunity. Thank you.
Thank
Thank
you
you
so
so
much.
much, ma'am.